So it's an absolute delight to be here. I always sometimes get a bit nervous talking to patients, but I'm really, really glad to be here. And I am going to be hopefully talking to you today about clinical decision support tools, and what exactly they are. And I wanted to give you some of the examples of clinical decision support tools that we've developed in Cambridge. And I also wanted to spend a bit of time talking about the barriers we face in developing them and why it can actually be really challenging. And I think a good way of understanding clinical decision support, it's about how we take, in our case, algorithms and how we translate them into better patient outcomes. That's fundamentally what we want to do. So I wanted to start off what exactly is an algorithm, and it's basically a fancy word for a recipe that has defined inputs and steps and outputs. So the deal is, if you put in the same inputs, you will get the same outputs if you follow the same steps. And a normal recipe, that might be eggs and flour and milk. And when we talk about clinical decision support, your ingredients are somewhat different. It might be height, it might be blood pressure, it might be current medications. And despite our fancy names for algorithms and clinical decision support tools, it's not actually a particularly new concept in medicine, and it kind of stems from the increasing scientific approach to medicine that evolved in the 1800s with people like William Osler. And you can see on the left-hand side here, we've got a very nice flow chart, which is effectively, it can be thought of as a very simple clinical decision support tool. So if somebody comes to you with a fever, then you're going to look for some certain things. You're going to look for an infection, or you might look for respiratory systems. And depending on that, what you find, you will do certain activities. And so these kind of clinical support tools have been around in medicine for a long time. I've given you another example on the right-hand side, which is this thing called the Glasgow Coma Scale. And this provides a practical method for assessment of impairment of consciousness in a way that hopefully different clinicians would arrive at the same answer. And the deal is here, you have three categories that you want to investigate. One is whether a patient can open their eyes, one is whether you can get a verbal response, and one is whether you get a motor response. And then you add up all the responses you get. So if someone can spontaneously open their eyes, you get a 4, and then eventually you add up all your numbers. And the point of this is it gives you a reproducible framework to arrive at a set of actions. And so in a trauma center, you might have a specific protocol that kicks in if your Glasgow Coma score is below a certain value. So all clinical decision support tools really they're usually computational tools that are designed to reduce the cognitive burden, that mental load on clinical teams. And ultimately, the reason we care about them is they're there to improve healthcare quality, improve outcomes, and importantly, in this day and age, improve efficiency. So in this day and age, no talk is complete without the mention of AI. And so increasingly, we see that artificial intelligence is being used for clinical decision support. Artificial intelligence is coming into clinic with the aim of giving better outcomes to patients, reducing treatment overheads, and generally making our clinicians' jobs much easier. But I wanted to start off with a bit of a what I mean when I'm talking about AI, because it's a complete buzzword and it's bandied around all over the place, and it can generally mean different things. So artificial intelligence is about creating systems that can perform intelligent tasks, and that's about mimicking human cognitive abilities. So a machine can look like it's learning, it can look like it's reasoning, and it can look like it's perceiving new things. And it encompasses a range of technologies and methods that enable machines and computers to operate autonomously, that they can adapt to situations intelligently. And so you can see here in this little diagram on the left-hand side that there are subsets of artificial intelligence. And one that you might have heard about is called machine learning. And an example of that is we can train a machine, we can get a machine to learn how to recognize cancer cells in a set of pathology slides. So when somebody might have a biopsy, we'll take their cells and their tumor off to the laboratory, we'll put it on some microscope slides, and you can train a computer to identify the cancerous cells within there. And that's actually really advantageous to us because it's actually quite a manual job and it requires a huge amount of clinician time. So if you can reduce some of that burden, that's a massive clinical support tool that can then be passed on to a clinician, to a real human for review. And we have other subsets of that technology as well. One you might have heard a lot about is large language models, and that is the chat GPTs of the world that are coming to prominence over the last year or so. And these are methods that allow us to interact with the computer in a much more natural fashion. The idea you can ask it questions in the same way I might talk to a colleague. Right? And so it's very easy to think of AI as being an all-conquering overlord. And actually, that's not necessarily the case. AI can encompass it in clinical decision support in general, can encompass a wide range of effects and actions. And I wanted to draw parallels between clinical decision support and support we see in other areas. And the example I wanted to use was effectively self-driving cars. And so in the middle, if you have a new car, it might come with a technology that's called lane assist. And this is basically part of your computer that just keeps an eye on whether or not you are sticking between the white lines. And if for whatever reason you veer off the lines, you will get a gentle nudge on your steering wheel that says, oh, hang on, just letting you know you're veering out of the lines. But it knows that if you're deliberately changing lane or overtaking, the warning doesn't kick in. And so at all points during this process, you're in control. It's just a nudge. It's just a gentle reminder that actually, do you really want to be doing that? And on the far right-hand side, it's an example of a completely self-driving taxi. This is a Waymo taxi that's perfectly capable of navigating around San Francisco with no human intervention. And so that is the absolute extreme end of decision support. At that point, we don't actually need human decisions in the loop at all. And so when we talk about clinical decision, there's a huge spectrum of areas where you can intervene. It might be a small alert or a small reminder. It might be diagnostic support. And ultimately, it might even go as far as, replacing a human decision maker. But I don't think we're there yet. Okay, so if that's what we mean when we're talking about clinical decisions, why do we need clinical decision-making support? Why do we need it? What's the actual point? So medical data is growing increasingly complex. Patient care needs are increasing. And also, as we see this ever increasing complexity of data that we deal with, we see increased errors, and we want to see, ultimately, we want to see improved outcomes. We don't want to see increased errors. And so I've shown you here a picture of an oncology multidisciplinary team meetings. And in the majority of hospitals, key decisions about the treatment of every cancer patients are discussed in a room like this. And we have radiologists, pathologists, oncologists, nurse specialists, and lots of professional expertise in this room, all giving their perspective on the case and all presenting their data from their specialty and biomarkers. And it's quite a unique way of working, and it captures a kind of complexity of all different data points we deal with when trying to treat cancer as a disease. However, the efficiency of this is questionable. This is the most expensive meeting that the NHS runs by the time you add in all the salaries and the time involved in these meetings. We generally take hours and we discuss, 40, 60 patients in each meeting. And because we bring such a raft of data, and because we bring such a raft of different expertises into the room, sometimes our meetings end up looking like this. And so we have actually a huge amount of decisions to be, and you will see if all of these kind of questions that we discuss are actually ripe for a little bit of a nudge, a little bit of support that says, actually, we're not going to discuss this patient this week because the pathology is not ready, but that means I know for this list of patients, we need to go back and check the pathology is ready. It's ripe for a system that allows us to say, of all the other patients with the same biochemical and genomic markers, we know what the outcome was when we undertook a particular course of action. And so these are the kind of questions we want to help answer with clinical decision support tools. And it's answering those really real world questions and our ability to understand the ever increasing amounts and complexity of data we get, particularly in the field of cancer. So now I wanted to show you a couple of examples of clinical decision support tools that have been developed by my colleagues in Cambridge and that are in use day to day at the moment. And the first example I wanted to give is this example of the Predict tool. This is developed by my colleague, Paul Farrow, who's now in the States, but it's a really nice example of quite a simple tool that has been designed to be used by patients in conjunction with our clinical care teams. It's free and it's web-based, so it's quite simple to use, and it's a prognostic tool. And what it is attempting to do is that it's attempting to help patients understand the amount of information that they need in order to decide whether or not they should pursue a particular treatment after surgery. And in this case, what I'm showing you here, it's for surgery after breast cancer. And you can see with a shot I've taken from the website, it takes a relatively limited amount of information. And importantly, all of this information that is patient-specific clinical data and pathologic data, is available routinely for NHS patients. There is no extra data required. All of this data is extremely readily available. And you can see things it's asking for. It will ask for things like age. It will ask for tumour size. It will ask for a number of different factors. And the tool is designed to be used by patients with their clinical teams. And once you put in your information, women are shown a very visual chart. And the point of this chart is to help them understand what increase to survivability women like them will achieve should they choose a different treatment option. And you can see here, for women that decide to have surgery, 100 other women, like the person for whom is using this tool, 87 of them will still be alive in 10 years. And if that woman should choose to have hormone therapy, the survival rate is 89 women out of every 100 will still be alive in 10 years. So it's a visual representation that we know gives patients more power when deciding what treatment they would like to pursue, if any, going forward. And so it's phenomenally successful. It's used around the world. There are a number of different modalities now. We also have Predict Prostate and Predict, I think, Kidney is in the works as well. And so it's been generated by academics in the University of Cambridge, and it is not AI. This is a standard mathematical modelling technique that's been used to incredible success, and it's updated as more treatment modalities and more information comes online. The next example I wanted to give is somewhat more sophisticated. So for those of us who are diagnosed with cancer, which is roughly around half of us will get radiotherapy. And radiotherapy is actually quite an intensive treatment modality. It takes a long time to plan, and it's involving the use of radiation to kill cancer cells. And so radiation is very effective at killing cancer cells, but it's also damaging to healthy cells. So when we are planning how to treat a patient with radiotherapy, we target the radiotherapy such that it interferes as little as possible with healthy tissue. You want to minimize the damage to healthy tissue. And that's what my colleague here, you can see Raj Jana, who's a consultant clinical oncologist, does as his day job. He spends a lot of his time planning radiotherapy treatment for patients. And particularly in head and neck cancer, we really do want to avoid damaging healthy brain tissue as far as possible. And what that used to look like was people like Raj would take a brain scan in 3 dimensions. So you had the X, Y, and Z planes, and they would manually draw around what they thought was a tumor on all of these individual slices. And they would repeat that for all of the different approaches to this tumor. And it takes hours, and it takes someone like Raj, who is an extremely experienced clinical consultant with decades of experience. So it's a challenge for a number of reasons, not least because of the time, but also because of the experience you need to do this well. Happily, this is a task that computers are really well suited to, and in particular, machine learning is really well adapted to. So Raj collaborated with Microsoft, the technology company, and they put together a machine learning model that is capable of doing this, of automatically segmenting these tumors, of automatically establishing what it thinks is tumor and what it thinks is healthy tissue, and that can then be used to spare those healthy tissues from radiotherapy planning. And I'm going to give you an example here of the model in use. And it is simply someone taking a mouse and drawing around the tumor in one axis. And then we change to a different axis and we do the same thing. And then very, very swiftly, you will see that our model is able to outline what it thinks is a tumor area and that should not be targeted, or what should be targeted for radiotherapy planning. And you will note that happened extremely quickly. So we do need to pay for computational work. It's not free, but for around £7,000 worth of cloud compute, we can save around £200,000 worth of consultant time. So we can use a computer instead of people like Raj, and it frees up time for people like Raj to spend with his patients. Importantly, it means that precision radiotherapy can be prepared around 13 times faster than the conventional method. And most important of all, around 120 patients a month can start treatment more quickly as a result of this technology. So this is really advanced level clinical decision support that really, really absolutely makes a difference to a number of things that the NHS really cares about. It makes a difference to workforce, and it makes a difference to outcomes because we can get patients into treatment much more quickly. Okay, so hopefully I've been able to give you some examples of what we mean when we talk, some real world examples that have been developed by my colleagues in Cambridge about what clinical decision support tools can do. And so now I wanted to talk to you a bit about some of the barriers we face in developing clinical decision support tools. That's people like me and my team and my colleagues, when we try and take what we know from our data models in the lab and try and translate that into the clinic. And so it's a translation problem that's very, very similar to translation problems we find in other areas. So, for example, if somebody has a new drug or a new compound and they want to take that through to the clinic, there's a very well-established path in which you can follow to design your clinical trials and to get your therapeutic into the clinic. So clinical decision support methods face the same challenges, except with an extra layer of digital and technology barriers on top that we are not 100% sure how to navigate our path through yet. And I kind of liken the process to sometimes if you've ever read a set of DIY instructions where the first step might be extremely straightforward and you just have to draw a couple of circles and it's all fine. That's very much equivalent of trying to do this kind of work in a lab setting or a research setting. And then you go through your instruction list and all of a sudden between step 2 and step 3, there's some insanely complex process happens that is kind of summarized in one handy step that says, draw the rest of the oil. Drawing the rest of the oil is the difficulty we face in getting into the clinic. It covers a multitude of things. So why is that? So this is the Cambridge Institute. It's a building on the biomedical campus. It's where I work, and I have the privilege to work with some of the most intelligent and creative and scientifically adventurous people I've ever met. It's a brilliant place to work, and it is dedicated. Everyone in this building comes to work every day to make a difference to our ability to treat cancer. And most of us are scientists. And what scientists like to do whenever we have done a project is we like to write papers. And I wanted to give you an example of some of the papers that this institute has published over the last few months. And if you understand even half of these, you are better than me, because you will see we publish a wide and extensive variety of really quite complex subjects. And what we can find is some of these include clinical decision support, and a lot of the technologies that we put in this are really, really quite advanced. So you will note that there is a long way between reading some of the summaries of the work that we have published recently and answering the questions that you saw earlier on, such as, oh, hang on, should I treat this patient with chemotherapy or not? So one of the struggles we have is making sure we can take all of these amazing advances in scientific research and translate it into meaningful answers to clinically relevant questions. And I wanted to drill down to that a bit more in my next slide. And this is an example of one of many papers we have published where we have something that is effectively a fledgling clinical decision support system. And it's got a very fancy name. The title is Multi-Omic Machine Learning Predictor of Breast Cancer Therapy Response. And what that means is basically this is a method that uses information we know about a patient before we treat them to estimate a probability of whether they will respond to that treatment or not. And given some of the cancer treatments we offer our patients are cytotoxic, they're not pleasant, they come with numerous side effects, and they're expensive and unpleasant to endure. Actually, we really do want to know that if we're going to treat a patient with them, that they are going to be successful. And so that is a driver behind this kind of research. And my colleagues here in the CI built a very successful machine learning model that could predict in advance about whether or not a patient would respond to particular kinds of breast cancer therapy. And in order to do that, we have access to some really cool infrastructure and some really nice toys that if you're a scientist or researcher, they kind of keep you happy. So we have access to some really exciting computational infrastructure. So we have a whole team of people here in the Cambridge Institute whose job it is to keep very fancy computers up and running 24 hours a day. We also have access to a huge amount of extra data that we just don't have available in standard of care in the NHS. So we have, for example, information on a patient's immune response, to their tumor already. We have extensively curated access to their medical records. So that's lots of data that we have teams of people who pore over, neatly package it up, and put it together in a structured format. We also, in the CI, we have a core genomics facility who can do all kinds of really, really exciting sequencing technologies so we can understand that tumor in unprecedented level of genomic detail. And also, as researchers, we have access to really, really fancy medical imaging, so metabolically aware imaging that can understand whether or not a tumour is responding within hours of administering the therapy, and lots of other really, really exciting research-grade technologies. And perhaps more importantly, we have time. I mean, this piece of work takes years to pull together, to collect that data, to curate the data, to build the models and validate that. So just across the road in oncology outpatients, it's a somewhat different picture. We don't actually have access to very sophisticated computational infrastructure to run the kind of heavy-hitting deep learning models that we produce in the lab. We don't get immune data as standard of care treatment for a patient. In order to have that data in the NHS, we need to prove that it is worth the while collecting that immune data. Once you've made the case for saying, actually, NHS, this data is valuable, you then need to create a valid method and a method that is subject to audit and regulation to collect that immune data. We do, however, in CUH have an extensive electronic medical record, and CUH is absolutely at the vanguard of the e-hospital and digital transformation of healthcare. We are extremely fortunate with the electronic patient record in CUH, which means we have access to around 11 years of patient data and patient outcomes. So that is absolutely a real feather in the cap of CUH. It's brilliant. We do get access to some genomic information through the NHS test directory, but actually it's only a really small subset. And again, for that particular piece of information to be included in the standard of care test directory, it's been through a really rigorous process, and it has really pros in it as well. And perhaps more importantly, we are working to clinical timescale pressures. Well, not only do we have the NHS timelines for delivering treatment, we really want to make sure we can offer the benefits of these things to our patients as quickly as possible. And that's a world away from the timescales we work in the research setting. So when you come up with clinical decision support tools like this in the lab, you're working in an environment that doesn't actually match the real world at all. And if you want to bring these clinical decision support methods into practice, data is absolutely critical. And dealing with data and the complexity of data that we need to support this next generation of clinical decision support tools is still something we're trying to get our head around. So if you look at all the different data points we have about a patient, we will have genomics, we will have digital pathology, and the trust is absolutely at the forefront of digital pathology. We have a clinical record, and we have medical imaging, X-ray, CT, MRs. And we need to choose this data carefully to understand we're making the right data entry, the right ingredients to our clinical decision support. We need to understand bias. If we build a clinical decision support method only on Cambridge data, that data will only reflect our Cambridge population, and that is extremely different from a population you might see in a large London teaching centre or you might see in Cornwall. And I've used the acronym here, GIGO, which is garbage in, garbage out. If you feed your model per data, you're going to get per data out. And as far as possible, we really want to use routinely collected data, because that means if we want to take our clinical decision support method into the clinic, the data we need will already be there. Curation is an issue. So for research-grade data, we generally have people who will carefully curate these data sets. That's not feasible in the real world if you want to do that at scale. So deploying clinical decision support methods in the trust, you need to understand whether your hospital IT is set up to allow these complex data methods to run. And importantly, are they regulated? Is it software as a medical device? And how do you get your technology certified? This is much less straightforward than other therapeutic interventions we might want to do. And finally, is it actually worth it? Is your method useful to clinicians? Is it a good use of resource when their trust has 101 other financial priorities it wishes to address? And so this is all very much encapsulated in what I tend to call the last mile delivery problem. And so here on the left-hand side, you will see the Cambridge Institute where I work. And at the top right-hand corner, you will see an image of the new Cambridge Cancer Research Hospital. So these two buildings are separated by probably a bit less than 250 meters. And if I look out some of the windows in this building here, I can see an army of diggers busily conducting enabling works on that campus. So even though we are only separated by a couple of 100 meters and a well-thrown cricket ball could probably hit the sites, we are separated by at least 5 years in technological terms and in our ability to deliver clinical decision support methods into clinical practice for patient benefit. So the research output, the writing the paper that we as scientists are also proud about, is absolutely only the starting point. We then need to follow a really extensive process of how we get that model ready for prime time, how we get it into, how do we do that last mile delivery problem out of the clinic, out of the lab into the clinic. And we have to do a lot of work around the data, making sure our data is valid, Have we validated the data set? And can we make sure that our model is robust enough to interface with real world data from a number of other hospitals? A real technological problem we have in deploying these methods is mapping. So say, for example, our model, our clinical decision support tool, is looking for blood pressure as an input, as an ingredient into it. At that point, we need to ask the clinical team, the e-hospital team, well, where do you store blood pressure? Where does it live in your system? And what format do you put it in? And is it the same format we are looking at? And does it change? And if it does change, will we know that it's changed and therefore we can update our model accordingly? And think about doing that for maybe the 10, 20, 50 parameters in a model, and that's quite a lot of housekeeping. Also, information governance is an absolute priority to make sure the use of data is safe and appropriate and ethically approved. And again, increasingly, if you look at computational models, which have the ability to be deployed in the cloud or in the trust, we need to know who can see that data, who can run that model, who can interfere with it if necessary, if they have bad actors. And that, again, is a challenge in a way we don't usually face with other clinical interventions. I've already briefly touched on compute. Is it available in the clinical system? How much is it going to cost? And the big kind of bête noire that I don't think we definitely have a nice, robust answer to yet is the idea of regulation of clinical decision support tools. For those where we really want a high level of support, they're generally classified as a technology that's known as software as a medical device. And that comes with all kinds of regulatory overheads for absolutely good reasons. But postdocs and scientists working in academia generally are unfamiliar with what it takes to write software and write code and build models to the level that regulation insists upon. And the analogy I like to use is that if we were to develop a medicinal compound, it would be really easy to hand it over to our clinical trials unit, who know all about delivering clinical trials to develop evidence bases for an interventional medical product, a new drug. That framework does not yet exist for clinical decision support tools in the same way, and that is something we are actively looking to address for the future. User design, this is really important too. You know, if you have a pill or an injection, everybody knows how to use a pill or an injection, but are we asking clinicians to learn new user interfaces for a number of different clinical decision supports? That's not really feasible, and we need to really carefully consider how we ask the clinical teams to engage with these tools as well. And finally, it needs to be available. Clinical decision support tools need to be available at appropriate times in the clinician workforce, whether that's in the scenario of an MDT meeting, whether it's an outpatient clinic room. You really need to understand where these models are used, where they make a difference, and what the barriers are. And so those are the majority of the steps we need to consider to get our innovations, to get these tools, these models that we think improve patient outcomes and improve clinician experience into the real world. And the final point I want to make on this slide is that I said that this timescale is generally 3 to 5 years at a minimum. The average scientific research grant for a large program grant would be around 3 to 5 years. Large language model technology, ChatGPT, came onto the scene about a year, 18 months ago, and it has already transformed the way we conduct research and the way we engage with many things in our day-to-day lives. In 6 months or so, that will probably be superseded by the next generation of large language models. The current funding stream, the current regulatory stream simply does not move that quick. And so we have this real disconnect, this real two-speed system, the speed at which our research and our ability to build these models moves at versus our ability to get them into the clinic. The ability to fund projects like this and the ability to deploy these methods in the clinic takes orders of magnitude longer than the speed at which technology is moving forward. So what are we going to do the way forward? I kind of wanted to finish an optimistic note, and I think these changes will happen, but fundamentally we are all working towards better outcomes for patients and clinical teams that really help make sure that clinical teams can take advantage of the increasingly complex amount of information we have for patients. And we want it to help reduce the burden on the NHS workforce, which is really severe and really significant. And ultimately, these clinical decision support tools are enabling us to build more tailored approaches to clinical care because we are taking more specific data points from each patient for these methods. We also think we're going to get more and more data, even though we already know there's a data tsunami that's kind of overwhelming at times. That's only going to increase. We're going to be able to access more data from wearables and other mobile devices than we ever have before. We're also going to be able to access this data in real time, really, really quite soon. And I think also, as we are asking these clinical decision support systems to deal with more and more complex data sets and the interplay of more and more complex data streams, they need to be explainable. They need to be able to return to the user, the patient, the clinician, an explanation for why that clinical support system has made the decision it has, whether that is to treat or not treat, or whether that is to suggest a particular course of action or not. So I'm going to stop there. I think I'm on time so far, just double checking. And hopefully I'm more than happy to take any questions.